Okay,
Thank you.
let's do this. All right. Thank you, Rana. Uh, so as he introduced me, but let me give you a little bit of background that I have a long understanding and association with Africa. And previously, as I mentioned, that this lecture was meant to be only for African countries, but I can see that from the registration, a lot of participants have are from other countries. So just forgive me. I have to admit all these guys. This is crazy stuff. Um, so just a disclosure and a disclaimer, a little bit. Still, you can see my full screen. Is that all right?
Yes.
Yeah. So this is a
Yes.
personal initiative, and really here I'm not sponsored by anybody. And no company has sponsored me, and definitely I'm going to discuss some of the equipments from the different vendors, from Electra, maybe from BrainLab mostly, and a little bit from the SNC, but that does not mean that they have sponsored me. So that's important. And the first part of the lecture may be a little bit boring as well, because we are going to cover a little bit of the literature. And from the second lecture onwards, we will be really going to deep into dive for the real, the essence of what we are going to discuss clinically. The third part is very, very important because, again, there I'm going to share the experience of really putting up an SRS program in an existing department where we normally do, normally we met or conventional radiotherapy techniques, how we can. So that's what, and the third one, the last one, we are recording. So maybe at any point in time, it can be published anywhere in the streaming platform. So remaining here meaning that you are really consent to that one. So if you are not comfortable, you're more than welcome to leave. So, as I mentioned, let me give you a brief break history. So sorry, an overview rather, that what we are going to do for the last for during the next couple of lectures. Sorry, I have to admit the guys who are coming. The first one, as I mentioned, just we will go a little bit into the history, and we will touch also a radiobiological context as well, because you might know this linear quadratic model. I'm going to touch that one, and only maybe two slides. Let's see, sort of comparative analysis between gamma knife, cyber knife, or the LINAC. But our focus is on LINAC, so I'm not really going into any complexities or any advantages of going through the gamma knife or cyber knife. So you know those. I'm not going to go there. From there, the lastly today, because after making you a little bit bored, I want to go into really into the practice, and that was not my plan initially. So we will be discussing a little bit of the small field as well, because I was trying to cover the technical aspects in the second lecture, but it was not possible for me to really cover everything. So I'm going to discuss the small field as well here. So in the second one will be very, very technical. And for those who are radiation oncologists, it is important, but there will be a little bit of some dry stuff in there. So if you are really interested to go into that thought, you can join. Otherwise, it's up to you. But definitely understanding those technical aspects is very important for a radiation oncologist and a therapist as well, I would say. The third one will be very interesting because that will be a sort of story right from the beginning, and the way we commissioned all our equipment, starting with the map check, film dosimetry. My more focus will be on exact dynamic as well. That was because running in parallel with what we were doing, because that was the most important thing for us for exact. There are a couple of others, but in the market, but for some reason we have the exact rate. So and then the end-to-end plus the audit, and the lessons we have learned over the 2 years, that will be an interesting subject as well. For regarding any questions, I'm open. If you can stop me at any point in time, because the mics you can open. But if you want me to keep at the end of the session, because I will try to my best to cover this stuff within an hour, and then we can keep the floor open for any question. But meanwhile, if you really think that it's important, we can discuss. But my request would be, if you're not asking, you can just mute yourself as well. So now let's go to the some of the learning objectives for today. Definitely is the clinical rationale, right? Why we are interested here. That's the point. And some of the historical background. Is it something new really, or it was there and then we abandoned and we started again? So that's, and secondly, radiobiology, because without discussing radiobiology, radiation oncology, radiotherapy itself is incomplete. So let's see how we can apply, where we can apply. Is there any limitation of the existing formalism for radiobiology? So we will be doing that. And technology, as I mentioned, I'm not really interested in this part of the lecture where my focus is only on SRS, Linux-based SRS. And the prerequisites, the AAPM is really making our life very easy in many ways because of these protocols, the way they publish and the guidelines. And the recent ones are the MPPG, the Medical Field Practice Guidelines, 9B. And you might see today that we will be touching the small field dosimetry protocol as well, TRS 483. And I'm going to show you just a pathway here, but in the third lecture, we will be really going into a little bit deep in this part, especially end-to-end, go live, and the patient-specific QA as well. And definitely throughout the discussion, anything which we are discussing about the QA or anything, or any tolerances, limits, if I'm showing you, then those are based on the protocols, the standards, the framework given by the TG 142 or TRS 403 or 101, and there might be a couple of others as well. Clinical rationale. This guy, I must say, this guy was a genius. And there is a particular reason I'm saying that why this guy was a genius is that without studying really mathematics and physics, he was the one who invented the concept of stereotaxy, right? So really rotating something in three-dimensional space. And during that time, there was no really cone beam imaging. There was no really external beam imaging. And this guy did something extraordinary. And now you can see everything is very, very easy for us doing surface guidance and 3D imaging. We can locate everything pretty much in three-dimensional space. And now you will see later on, and I will be discussing the exact rate that how that is capable of even looking at the surface, looking at the temperature differentials within your surface and the internal bony landmarks. So from here to here, but the credit goes to this guy. So he was a doctor, he was a neurosurgeon, and that was the big achievement. All right. Again, as a history, you don't need to really remember, but just to make this educational activity a course, and therefore it's important to go a little bit of the literature, and you will see in every textbook this is the guy who will be mentioned as a Lexel stereotactic method. He was introduced in Stockholm. And then the first gamma knife, everyone knows that we use cobalt 60 in the same as spherical arrangement, and the resistance of beams hits normal the common center. And then with the in 1982 started. Trying to mute the guys as well. Sorry for this, man. We started the first Linux-based SRS during this era, and you can see how we managed to do that. It was sort of a bit different way, the way we are doing now. And here you go, the Winston Lars. This is the first dead ball bearing. And my second part of the presentation will be revolving around this Winston Lars. You might get bored as well by what I'm talking about. The good part of this, we are still using after many, many years, you can see. And and then it evolved. No need to say anything about this common cyber knife, and then the double APM, they really start thinking to change their protocols, that how we can differentiate, how we can tailor our tolerances, protocols, procedures, so that we can really cover this sort of small field and such small tumors, and particularly the hyperfractionation, which is really dangerous. We will see later on what I'm talking about. And then recently we have the new protocols where they have mentioned pretty much defined, even they have given you the guidance in terms of the staffing, the prerequisites, what you needs to be done, QA requirements, pretty much everything you need to follow. So that is good. And now my focus will be later on the exact check. This is not exact check. I just put a reference diagram. I don't have an experience with the line RT or the C-rate. My experience is with the exact. So during the lecture, my focus will be on. Again, an announcement, please, once you join, please try to mute yourself so that we cannot get disturbed. So the clinical indications, as I said, I'm not a radiation oncologist, but we are working with the radiation oncologists, and currently we have a limited scope of delivering the SRS for particular diseases. It is a very vast, you can see from this one, that here mostly our focus is the brain metastasis. But it can be really used for many other sites, right? Meningiomas, acoustic neuromas, pituitary adenomas, high-grade gliomas, the arterial venous malfunctions, trigeminal neurology, and many, many. This is the one which I have a real clinical experience of doing this. Second one is very common for us, the spine SBRT, and I hope I will be able to share you some of the plans as well, because really in this lecture, I'm not going to really discuss anything about the planning or anything, because that's commonly discussed by everybody, but might be I will be showing you how we do QA, what makes it different than the other SABRs. The lung cases is very, very common for us. Liver SBRT and the SABR. Now, these are the very common, really standard radiotherapy techniques. If you go, there is the concept of the VMAT and all the stuff are going a little bit in the downwards direction, but now the SABR and the SRS is in the key standard. So if you differentiate, it's very clear here, right? So we are here in conventionally we give 180 centigrade to 200 centigrade. That's our nominal dose rate, but now you can see once we exceed this one, then it becomes a stereotactic. We will come to this, a bit of radiobiology. Rather, I must say here 10, not 8. So, and then depends on the number of fractions people give it. If it's a single fraction, it's normally it's given name and SRS, right? It's for the cranial cases. But if it is the other than the cranial and it is fractionated, then people call it the SABR or the SBRT. I will be discussing a lot here on maybe in the second lecture about the margins, because as a physicist, we are the ones who will be responsible that what should be the margin, right, and based on what. That's important. But in case of the conventional radiotherapy, you are fine with one 5 millimeter, 10 millimeter, 15 millimeter, but that concept is not applicable anymore. And why, we will be discussing that. Why 0 millimeter margin is important? That's the question, right? So sometimes we go 1 millimeter, and at what instances we have to go to 2 millimeter, and what are the disadvantages of doing that? And here, one more important thing is that the sharp fall off, the gradual sharp fall off per millimeter for conventional is very different than conventional. It's very, very steep. There's a big difference between 1 to 3% and 10 to 15%. And there must be a rule of thumb, right? So that's what we want to achieve. And why we want to achieve, as you go along the course, you will understand that why. And this is not really optional. I mean, definitely most of the machines now are coming with the CBCT. But here it's sort of mandatory the 6 DOF should be there. Without really 6 degrees of freedom, you can't achieve that sort of accuracy, and definitely interfraction monitoring. In this part, we will be covering when we discuss maybe in the third lecture, when I will be discussing the exact track how we install. And I think I can mention, as I mentioned, 1 millimeter is unforgiving, and you need that level of accuracy. And this is the radiobiological principle that how the repair works. But here, this is a totally different concept. I'm going to discuss this one in the couple of next lectures. The cell kill plus, this is an extravascular plus the immune. We will be discussing that. But so far, if you have really anything which is not, if you are not in agreement with what I'm saying, we can discuss for maybe 1 minute or 2 minutes. If not, we can move on. For any implementation for clinical practice of any new modality, particularly in the field of medicine, and especially in the field of modern medicine, which is radiotherapy, and particularly in the radiation therapy, you need those sort of trials, right? To create some evidence. And without evidence, you can't really practice, because it's evidence-based medicine. So there are a couple of landmark trials and their impact, and the data is really showing that for some of the cases, SRS alone is the real standard of care. And these are some of this. You can see the SABR commit, which was published in 2019, and you can see the overall survival. Very 41 versus 28 is a big difference, right? For the 5 years. And this was the first randomized trial particularly for oligometastasis cancer, which is very common. And this one was particularly for the brain. And you can see the overall survival was comparable, but the big difference was in terms of the cognitive decline, 91-63, big difference. Because normally, I remember we used to do many years ago, just straight away the whole brain was the standard practice, but that's not anymore. Similarly, this one, under local control over 3 years for the SABR cases, it was very good. For the lung cases, here in Australia, where I'm practicing, definitely lung SABR is very common and it's very standard normal practice. Same, I mean, for prostate, again, this is becoming a sort of very standard practice for SABR prostate. Yeah. Okay. Let's discuss a little bit of. I think I'm going very slow. Already 24 minutes. All right. So let's go a little bit to discuss radiobiology as well, so that we need to justify a little bit of our dose fractionation as well, right? So based on what? Because conventionally we have been doing this, but all of a sudden what happens? Some clinical indications for the SABR. You can see if you just observe, you can see the local freedom of the recurrence rate. It's very low, but with SRS is improving, and you can see. We will see later on that for the SRS and the SABR, the dose is the only determinant factor. That the higher the dose, the greater will be your local control. That's the key. And for achieving and delivering this much dose in a single fraction, the level of accuracy you need, you can understand, and the level of burden on we as a physicist is very crucial. And we will be dealing that what I'm talking about. And again, the numbers are very good once you are given doses in this range. As the doses are dropping, and the outcome is low, just like you can see. Sometimes we are forced to give less dose. As I said, I don't have a time under what conditions to do this, but that's the only determinant That's the factor. All right. It's a clear indication again from the figures. It's the self-speaking. Can you mute yourself? I'm not sure who is the guy. I will make sure next time I will change the settings. All right. Again, you can see as the dose, if the dose is greater than 21 or is just equal to 21, the local control is almost 100%. And as the dose is going down, you can see, and there is no any linear correlation between. Can you mute yourself, please? Whoever is. Burhan, can you try to unmute? Maybe you are from my company. I'm sure you must have rights. Mute all. Okay.
What do you need?
If somebody is not, can you able to mute anybody? That's fine. All right. Again, not going to details with the advent of the X-rays. Here is one thing surprising, that we started radiotherapy with the hypofractionation, because previously with the advent of the X-rays and the radioactivity, it was a single dose, right? But once we learned, because there was no concept of radiobiology at that time, and this is a well-known figure from this RAM testes, the way they start doing the experiments, it's well-known. And then they found that really doing the fractionation is really helping us. After that, we learned that how the fractionated regimens can really help us, especially for the deep CT tumors. And that was the reason for doing the fractionation. And then, because at that technology, at that time, it was obvious, that was fine. But now with the advent, but this guy, we started again thinking after many years doing the SRS, and now we are here, and a lot of trials. That's what's leading to the SABRs. Again, as I mentioned, that the field was changing at a higher speed with the advent of the CBCT, and then the IGRT came into the field. We start really doing the 2D, 3D matching, 2D matching, and now we have the technology where you can really locate the tumor, really locate the patient in three-dimensional space in any plane. Previously, we were really forced to do the cone beam CT when the couch is zero, right? But you will see later on that how we are going to develop a relationship between the MV isocenter of the LINAC with the KV isocenter of your XVI or OBI with the external imaging. So with the advent, we moved on, and then we started developing the clinical evidence, and I show you all this before all these trials. So okay, so let's discuss a little bit that the application of the linear quadratic model for such a higher doses. That was the first question, because definitely in 80s, the radiobiology was established, so the formalism was pretty much matured, and we were in position to really define the dose perfection for pretty much, and we were developing a relationship between the fraction dose and the number, the BD and the AQDT formalism conversion. But the question was, can we really apply these formalisms straight away for such a higher single fraction? And the question was really no. So because it was really overestimating formalisms, because there were a few other things which were happening on a physiologically, right? So the rule of thumb is that up to 10 gray, that's fine, but after that, it's really overestimating. Additionally, I'm going to discuss those things as well. That why? Because after you are exceeding greater than 10 gray, the phenomena which is happening other than the cell kill is your vascular damage. And other thing is that other than if you have any metastasis outside your body, definitely there is immunity, which is called the abscopal effect, is kicking on, because your body has a certain um, im immune system, and if you are nurturing a tumor in your brain, and all of a sudden within no time, if you are killing with such a lethal dose, then what will happen to your immune system? That it will kick in, right? It will kick in, and it will try to defend. So while doing that, it has a, if there is any other thing which is outside that lesion, it will control that. So the current research is both based on uh, concurrent really immunotherapy with the radiobiology. So that was the whole thing, that the vascular damage plus the kicking of the triggering of your immune system was the one of the main reasons. Okay, I have just given you an example that how come yet you can see that if you are given a single fraction, and you can see how the difference is in terms of the BED and the EQDT. And again, I'm giving you some more examples. You can see this is a conventional way of doing it. And but you see, if you give us 20 gray, your BED, if you use alpha beta as a 10, then it's 60, and it's 10, EQD2 50. Meaning to give a 50 gray, definitely conventionally you have to do 200 centigrade per 25 fractions. But the impact of giving 20 gray in a single fraction is this. So that was the achievement. And as I said, it's not only the cell kill, and I mentioned previously, it's the vascular damage plus your the immune. So these are just giving you some examples that how clinically it works. You cannot really rely straight away on the figures given here, because as I mentioned, it's overestimating. Up to 60% is fine, but above that, there are other those physiologically triggered. Okay, just to give you this is more easy to understand. This is definitely the first shoulder, right, where you have the same stuff initially, but this is for fractionation, and this is the survival curve, meaning that the cells, remaining cells after irradiation. So this is important to differentiate. But you can see if you give that in a single fraction, just look at these red lines here for 12 gray. This is the survival remaining cells. There are very few. And if you do this, if you want to kill the cells and the remaining cells you want to remain this here, you need to fractionate the dose, and the effect will be equivalent. But here you can see you can do this in a single. So this is just to give you an example how it works. All right. We have to really rewrite the repair distribution, the 4 R's, right? And you can see that how single fraction is really favoring us. In repair is not more applicable here. Why? Because in the survival fraction, the formula, the second part, this one is dominant. Why? Because D square, right? So there is no repair really, because that's the dominant. So which is fine. So that's the reason that it's helping this 1 R, and the second R again is irrelevant. There is no time for redistribution. Straight away you are given within no time. So that's also helping. Repopulation, again, within minutes, no time for any clonation repopulation. The only thing is the reoxygenation, which goes a little bit against the SRS, but because the dose is so high and you are making a vascular damage above 10 gray, so that compensates. Otherwise, we need reoxygenation so that we want to kill those repairing cells, right? While doing their reproduction, we are killing in particular phase. But here there is no time for doing that. But as I said, the mention is the dose is so high, it's in our favor. The radio sensitivity and definitely the alpha beta ratio determines the SRS efficacy, and just like the low alpha beta ratio for prostate is really helping us, because once you do the BD calculation, you will see that the BD and the EQD2 is getting bigger and bigger. Oh, I have written here. So yeah, this is the conventional classical way, where you have a direct cell kill, vascular damage, which we mentioned. You are pretty much stopping the supply of the oxygen, the blood supply in there, and the immune activation, which I pretty much mentioned everything, but definitely this is beyond the scope of this course. This is for really for the doctors who are really studying the radiobiology, but for us to understand, it's not only the direct cell kill, but rather there are two other factors which are contributing. All right, so technology landscape, as I mentioned earlier, start that. Just let's discuss a little bit of the technology now. I'm pretty sure that everyone knows the gold standard for SRS, which we call it is the gamma knife, and there are reasons for it. Yeah, I'm not going into that detail. Neither I have an experience, but definitely this is the gold standard. Secondly, there's the cyber knife. We know that the way it can, the degrees of freedom it has, and but our main toy, which we are going to discuss for the next even two lectures, is definitely the Linux base, whether it's Variant or the Electa. That doesn't really matters. And the advantage of doing all this is because you can do really cranial, extracranial, and you can do the conventional, right? So that's the reason. And we will be using definitely 6FFF, and there's a reason for that. And if you have the HTMLCs, the lesser the thickness of the MLCs, the better. And we will be discussing that why we need this external imaging. What are the limitations of the LINAC, which are not really here. So, but we know that in terms of the overall survival from the literature, it seems like it's not about really the technology. Rather, it's about how we as a physicist are making sure that these equipments are capable, and we are making them capable, and we are creating robust mechanisms where the output is the same as this one. But we need to put a little bit of efforts here. We will be discussing in the second lecture, just to give you an idea that this LINAC is huge, right? And because of that, and it's huge and it's moving those parts around, sagging, the difference of the MV, external imaging to make a correlation between the its own MV plus the external imaging. So these are some of the issues we need to discuss. But if you know how to do it, if you know how to monitor it, then it's not something bad, and the results at the end you are getting is almost equivalent of what these machines are capable of. And the important thing is that you have to spend a lot of money to really install all this, right? But this one already you are using it. You need to just put a little bit of the efforts and make it reasonably good in terms of its tolerances to make it fit in that category. Because as I said, SR is about sub-millimeter, We will be discussing later on, maybe at some point in second lecture, that it's not about, we will be discussing not about 1 millimeter. Our discussion will be sitting around 0.4 of a millimeter, 0.3 of a millimeter. That's sort of precision we are talking about. But with such a big machine, getting that accuracy is a challenge, right? How we are going to manage that challenge. So that's the whole idea. Again, because of the time, I'm really skipping this. I can see that I'm running out of time. I'm skipping this because I have to discuss so many other things. Again, I don't want to discuss this. I have mentioned already, you need to put a lot of money to install all those, but for the Linux, most of the modern Linux are really capable of doing all this. And in terms of the outcomes for the patients is the crucial, which is the same. And the Linux is accessible. And this part is getting more attention. It's the single isocentral multi-met target. We might discuss this one as well. And this is adding more challenges for us, that because the brand mets, patient will not come with a single met, because if the patient is coming with a single met, we pretty much know what to do, how to do. We know the limitations, we know how to correct, but sometimes we are facing some of the issues on the Linux base if it is as a single isocentral multimet. So these machines are capable, but how we can make them capable with little bit of an extra addition and investment, it's possible, right? And the good thing is that we have regulatory pathway and the guidelines. And those guidelines are really free. It's available for anybody. And even some of the softwares are available free. We can use and utilize. All right. Just some important aspects because we discussed so many crucial important aspects, and this cannot happen, right, without a staff, without equipment, without the standards, without the policies, and without commissioning those equipments so that you can utilize them. That's the key. So I'm not sure how this is really applicable worldwide, because we are totally dependent on the AAPM guidelines and IAEA guidelines, right? Unless if some countries have their own regulatory and some of the stuff, they are recommending that for this one, the physicist should be a little bit of qualified. That meaning that he must be really went through a sort of registration or a certification, and then there must be a particular SRS training, and the full-time equivalent. I mean, there must be someone who must be leading that program full-time. And just like in our center, we must have someone physically present while delivering the SRS, which is not maybe applicable for all the cases, but it's important. And there are a couple of reasons for that. And definitely these are the key duties I'm not going to mention. And for radiation oncologist, again, without credentialing, he must be credentialed by someone who is already doing that. And training competency plus, this is very important, the peer review. We can't treat any SRS patient, SABR patients, without the peer review by the multidisciplinary team. It should go through the multidisciplinary, and then it can. Radiation therapist, pretty much, as I said, that they must be trained, right? There must be some competency sign off and all the stuff. And for planning, it's important, but nowadays we have the automation tools. I might be discussing some of the extra terminologies which we are not normally use in our ordinary conventional radiotherapy. That's the Pedic index, gradient index, and we normally use only the homogeneity index, right? But what's the importance of this one? definitely, if it is SRS, then the importance of V12 is crucial. And definitely the TPS which we are using, we will discuss that anyways. I think I have already mentioned, without MLC, we prefer this. There must be 6 FFF beam, definitely 6 TOF. If it is 6 TOF, I'm quite sure that it's capable of non-coplanar. And imaging, because my experience with SRS is on the Electra, so you might see the flex map more often, but it's the system calibration for the true beam. So whenever you see the flex map, don't get confused what it is. We will discuss in detail what does that mean. But in short, this is a system calibration where you in variant, it's pretty much simple to do, but in Electra, this is a little bit it's difficult. This is a hard way of doing it, but the point here is that understanding what does the and the stereoscopic cave imaging, and because as I said, I'm biased towards the exact track because that's what I'm doing on my day-to-day basis. And today I might touch this one a little bit of the small field, just to give you a flavor of the technical aspects instead of just discussing the theoretical aspects. And I might also discuss some of the work treatment planning algorithms and their capabilities, their issues, what needs to be looked at, and what makes us different from the conventional stuff. But anyone who is really willing to go into that way, then he or she has to really go through these reports, and they clearly mentioned their tolerances. Again, in the third lecture, we will be going through pretty much, I will be showing you the actual data, definitely by anonymizing the stuff, that starting with the acquisition, TPS commissioning, image guidance, dosimetric checks, one-to-one, end-to-end testing, and the external audit with the Steve Phantom. We haven't done the IROC, we don't need here, but we have done the external with the Steve fan, and we use films and the ion chamber. So this will be the third lecture, will be very interesting because I will be showing actual data there. All right, so this is just give you an indication what is going to happen in the next couple of lectures. And as I said, we have all the equipments: map check, arc check, film, ion chambers, exact track, and every stuff. So I will be showing something very, very interesting. All right, so everyone knows, right? Acceptance is the first part. If the vendor is claiming that these machines are capable of doing this, then how you are going to verify? You will be accepting the machine for those particular specs. In the presence of the vendor and the engineer, and you will make sure that everything is fine. Don't worry about this one. We will be discussing mechanical accuracy. What does that mean? And I'm sure everyone knows flatness, symmetry, and all the stuff. I don't need to discuss, but these are the stuff I'm going to discuss later on. The second phase is definitely the dosimetry. If you're using TG51 or TR328, that's fine. But I'm going to touch this today in the second phase, because before going anywhere, we need to make sure that we have real small field dosimetry done, and we will be validating. I will be showing you how to validate, and I will show you what kind of issues you can have if you are switching to different algorithms as well, with a real clinical scenario we face. All right. The third phase, the second part of the lecture is only, will be on the Winston Lutz. So So just forget for now. Just if you want to keep in your mind, you can. But this runout, this 3D residual, and all this information, we will be discussing in the second part. And these are very, very crucial concepts while implementing any SRS. And you will see that at the end that what I'm talking about. End to end, again, I will be showing you the whole results. And based on your country, then definitely the audit and the credentialing, what country allows you, it depends how you do that. All right, so now let's give you a little bit of the flavor. What's going to happen next? So these are some of the equipments I'm showing you because there's no space on here to put all the equipments which and the softwares we are using to show you really. Rather, I just to give you a little bit of an overview that this is the images of the ExactTrack console where it takes the orthogonal images and how it monitors the differential of the temperature on the body and how it creates the surface. This is the CIRS multi-slice phantom. I'll be showing you the results, how we put the films in there, how we verify. This is the SRS map check, how we validate our patient-specific QA. Just like this is from the Monaco, and we are using films and the software as well, QA Pro. So we will be showing you this one as well. And sometimes during the validation and the initial commissioning, and sometimes we use the point doses as well. And this is what I was talking about, the Steve fan. And this Steve fan, you can pretty much put the chambers, you can do the films inside, and then under really real anatomical conditions, you can do one-to-one and end-to-end testing using the Steve fan. And this is, I'm sure most of you have seen that the ball bearing phantom. The second lecture is revolving around the ball bearing phantom pretty much. And this is the PIPS Pro. We have the Electa. We are using the Electa given platform, online platform, what we call it Aqua, and that does pretty much for us. But we do have the software from third party, which we call the PIPS Pro. And you will see I will be interpreting the different concepts of the Winston Lutz, the MV runout, and the MV residual, and all those concepts and their relevance here, the second part of the lecture. This is how the Linux looks like. And you can see the X-ray tubes are down there, and you have the panels for ExactTrack, and this has the optical, thermal, and stereoscopic, those capable imaging, the monitor, and so this is for head support, and this is the frame. So the system looks like this, and from the conventional Linux, you can see the difference is that this must be 6DOF. We can't do without 6DOF. We will be discussing the reason why. We can't really do SRS with that sub-millimeter accuracy without external imaging. We will see. Why can't we really use only three-dimensional CBCT XVI imaging in this particular case, right? So we will see that later on, maybe in the second lecture. Because as I mentioned, this machine is huge. It has its own limitations, but it's up to us. We should know the limitations. We should correct them and deliver the right doses. That's the theme, basically. All right. So I think enough is enough now. A lot of theory we discussed. Let's go a little bit on the ground and discuss a little bit on the small field dosimetry. Why we need really small field dosimetry, and how we can really independently validate the TPS. Just like in case of your Eclipse, right? You can put the output factors up to 3 by 3, and then it does the extrapolation. But it's up to you now that how you are going to validate for the small fields. In Monaco, you have to give all the data back to vendor, and then they will do the modeling and give you the model, and it's up to you. But you have to do the validation once you get the model. So this lecture is not really about the dosimetry, or it's not about the small field dosimetry, but those who want to really know how to do in actual, because of the time constraints, I can't show you their stuff, but I will just give you a bit of it, right? So in small field, the first thing is the chamber. Everyone knows the conditions, right? I'm not discussing the conditions. The important thing out of these conditions is that there is no concept of the field size defined in there. So it's now becoming the field with half max. And I'm sure that everyone knows how to determine the field with half max from your scanning software. So this is the first condition for the chamber selection, that if this condition is satisfied by your chamber, then you can use it up to that field size. If not, you can't use it. Then the issues of the volume averaging will kick in, and then you will be underestimating. And I will show you some of the profiles where it may not really reflect, and your output factors can go crazy because your chamber is big and your field size is so small that it's not suitable, right? This is very pretty simple, because this is now we are talking about the lateral charge equilibrium, and everyone knows source occlusion, what's happening here. And you can see, I will show you this example, that if you use a chamber which is big enough, and it will mess up with your penumbra, and that data you are providing, either you are entering, because in Eclipse you are not really entering because they are not allowing you to do that. But if you are giving it to the vendor, in case of the Electra, then they are relying on your data, and then they will create a model based on what you have given, and everything will be messed up. And we have some practical experience as well. We will show you that one as well. The point here is that the VMAT model, which you must have validated in your department, is not telling you anything about the accuracy below 3 cm. And I will show you, or I will prove to you this statement, what I'm saying about. So the independent measurement is important. And then definitely the output factors must be measured using the TRS-4 at 3. And micro diamond, I have used this one. Stereotactic diodes, we have diodes as well, and I have used the film. So 3 of them I have used as well, but there are a couple in the market you can. And the correction factors are definitely applied, and they are given in the 4 at 3 for 4 diamond. I will show you a couple of them as well. And again, I will show you that how we can verify the SRS small fields either under the static conditions or even modulated conditions, and they are very crucial for passing failing of your patient specific QA at the end, right? Because the problem with the SRS, not a problem, I mean, but as per the regulation, you can't really deliver such a big doses. You can't hyperfractionate with such a big ablative doses without doing a patient specific QA in an end-to-end fashion, right? So I will discuss what I'm talking about maybe at the last lecture. Yeah. And just to give you an example, we have experience with the Monaco with the GPU. We use both Eclipse and Monaco, but on the Electra sides we use the CPU and GPU. And with the recent the advent of the GPU, we shift to GPU, and we found some interesting observations. Some interesting observations on how the GPU is overestimating the doses in the TPS. And I will show you now. And assuming that if you and the Electra is using the same data which you have given to model your CPU, may not be exactly the same. If you are even giving a new data to the Electra to model your GPU, it may not be the exactly same as, so because they are totally different, and on the physics level, the way they have been modeled is totally different, because this is all about the speed and this is most all about the accuracy. And sometimes you have to give, weightage, speed versus your time. All right. So the same is the case. I will show you a graph for Accurus, not AAA. We are not using AAA anymore. For Accurus, even I will show you that how the Accurus is really overestimating the doses for the field sizes below 2 by 2. And similarly, for field sizes up to here, greater than this, you don't need really those correction factors. They are 1 basically. And then once you reach here, one thing you need to remember here, while doing the small field dosimetry, if your correction factor is 10%, 15%, that's not making sense, right? But you need to be careful that it should make a sense. So the good thing about microchip, microdiamond, and is that they are reasonably good, those correction factors. All right. Already 1 hour is gone. Okay, I will try to finish it. So that's nice. So you can see here, we were trying to investigate a problem where the TPS with the GPU model was overestimating the doses while doing a patient-specific QA, and the CPU was doing well enough. The CPU was already established, validated, while the GPU was new and it was doing something crazy for us. Then we were forced to do really the small field dosimetry, and they verified the outputs given by both GPU and the CPU. And you can see here. You can see here, this is GPU, red one. You can see the field size is up to 8 millimeter by 8 millimeter. The difference is bigger. You can see it up to 9%, the difference. And within CPU, GPU, this was the difference. But the error only for CPU was reasonably good. This is reasonably good. For such a small field size, it's not bad. But for the GPU, it was too much. And when I plot the error between GPU and CPU itself, and you can see the difference. And after you can see the behavior, it was in this quadrant plus, mean GPU was higher, and at this point it was lower. But this was because this was from the map check. So you can see for the map check on the central diode, it was the reading. So you can see here, because the value you are getting to calibrate your map check is different for CPU and GPU. Therefore, you are getting even a difference here as well. But this was really alarming for us. So once you get such a scenario while doing clinically implementing something new, you need to go back to the fundamentals, right? Because now you need to rely on something which has a high resolution as well. So we did the film as well, and you can see there was a clear difference in the penumbra region, in the output, and the penumbra. GPU was good because this was already, as I said, already clinical. It was validated, and you can see the difference. The red one is the greater the difference, it becomes red, right? And you can see in the field edges, it was red. So this was for a sort of static conditions. There was no modulation involved. It was just one by one, hit the film, compared in the film software, and then we found this 2 by 2 as well, same trend. So you can guess from these pictures is that the data given to the Electra, there is a problem. The chamber used may not have sufficient resolution to really give you the real picture of the beam penumbra. So that's one of the indication. But here you can see it's good because the data you will be given to the elector to create a model for you will be based on what you are providing to them. They will process the data and they will give you the model. If that's wrong, then everything is wrong. So again, this is for VMAT. Now the previous one was just for the static field, just to see what's going on. This was the results from the map check. For the map check, what I did was I just created plans with the varying PTV sizes just to see where it breaks. Because this is a separate whole project, I can't show you everything, but just to give you an example that this is 1 cm PTV, and if you compare just those metrics given by the CPU and the GPU, you can see there's a clear difference in terms of the output because this is representing GPU and is higher. And here you can see the dotted lines are the measured ones, and the solid lines are the TPS ones. And there is overestimation, the KEX. And here you can see in the penumbra region also they are not in good alignment. But for the CPU, your gamma results are very good, but here the center, the gamma results are not good. So it meaning that the output factors were not right, which was the clear indication here. Here, the output was not right. All right, so what we did, the previous film results I was showing you was just for the static fields. So just to see what's happening on modulated fields, we created the plans, radiated with film, and you can see the same trend. The solid line is your TPS and the dotted line is your measurement. There is a clear indication of up to certain percent, up to 5%, 6% higher as compared to the measured one. You can see it's clearly here. But when you do the same calculation and compare the measured ones, you can see there is nothing. Very good agreement. So it means that there is something going on with the GPU model, right? So this is a clear indication. Because you have to rely on your measurements in this case. There's no other way of doing it because it has inherent issues with the film, but that you have to look at the trend and you have to do the couple of measurements and get some statistical confidence in there. So then we went for the TRS-4 at 3 formalism. This is what I was talking about. That where you have a micro diamond and the USCC13 and for S-cling, you can find this using the formula given, and then you can use the daisy chaining, which we did, and then the machine specific and the chamber specific factors are there. And you just put the formula, create your Excel sheet, and because as I said, doing the small field, it should be a separate lecture. It's a bit different. You can't just put a chamber and do the outputs. It's a little bit different. So I'm not going into the detail, but just to make sure that whatever we have done is right, we did 2 sides, and one was done here in one state, and the other was done in another state, and then we compared that they were overlapping. And then what we did, we took the outputs given by both CPU and the GPU and plotted, and we found that the same trend, the GPU is giving us a higher doses, right? So then this will be mess up with the small field dosimetry, and your results for patient specific will not be right. So they will be failing, and you can see here, it's just getting crazy here. So as I mentioned earlier, just out of curiosity, because our machines are also configured for the Eclipse as well, I just created the water phantom in the Eclipse and get all the output factors and plotted a graph, and you can see the Eclipse is doing the same thing here. And just like this. So, and then this was something it was in front of us, and we can see now what should we do now? What's going on here? So right for that, you need to really look for your data which you have given to your vendor so that it can create, the model can be created. So you need to really look at the quality of the data you have given. And there, what determines that your quality of data is good enough? That determines your selection of the chamber. That determines your the step sizes. That determines your the speed, and that how you have done your sweet spotting, right? Because in small field, the concept of sweet spotting is crucial, because chamber, just like sweet spotting, meaning that just like, because I'm sure most of you are doing the breckie, while doing you finding your air current strength and then determining, um, you find a sweet spot for the well chamber, right, where it gives you the maximum value. So same is the case for the smaller field sizes. You can't really rely on the lasers to do something and keep in the center, or you can't use 10 by 10 field sizes and run a beam, and the system can give you a kicks. But once you go to the smaller field sizes, the sweet spotting is becoming crucial. So here you can see the data which is in the uh, this color, the blue one, is the data given to the vendor, and the upper one is modeled by the TPS, and then there is a difference. The difference in the penumbra, meaning that the chamber used is not good enough, right? And you can see clearly, although this is, just make sure that these graphs are for 1%, 1 mil. I mean, they are under very tight gamma analysis, so don't get confused. This was an outlier because because I was using Monaco utility for doing a comparison. For those who don't know, Monaco utility is just like in Eclipse. Once you do your beam calculations after giving the data, and then you calculate it, you can go to beam analysis, and it can give you the comparison between the one you have given and the one it has modeled, and you can do the analysis for each profile, right? So same is the case for Monaco, gives you the option of Monaco utility, and up to 1 by 1 cm field size, you can pretty much compare all the profiles at different depths and all the PDDs. You can take all the information from Eclipse back to utility and the measure data, and you can compare. And then you can analyze what's going on here. So this was an outlier. Sometimes if your data is not smooth enough, then it does this. So you have to take into another software somewhere and smooth it, right? That was the thing. But overall, that was the major difference. But these small differences were just adding up, and the error was getting bigger and bigger. All right. So again, as I said, just to get more confidence, the same thing was done in different states for up to 0.6 of a millimeter to the 5 by 5, and you can see the trend is exactly same. So that was giving us an assurance that it's not really the machine, it's not the machine, it's the algorithm which is not doing the good job for us, right? So same. You're talking about 2 by 2, you're talking about 1 by 1. We are very playing around very small field sizes. Just make sure. Okay. And these differences are becoming red, but that does not mean, look at this scale. It's not something which is bigger, but yeah, but the difference is just sitting here, and you can see the gamma criteria, which is very tight. All right, so but once you just to see where it's failing and what's the upper limit, right? So we did the plans on 4 cm PTV sizes and they measured, and they were pretty much good. But once you go below, this issue was there. All right, so these so one more thing, that if you haven't seen all these SNC softwares and all the stuff, we will be discussing those SRS map check, and might be showing a couple of slides that how we commission, how it looks like, how to analyze, and we will be doing this as well. And I will be also showing you how the clinically relevant plans, which we normally call it netcom plans, were validated um, uh, with varying complexities, that can be shown later on. But yeah, some of the stuff, if you see and it's not making sense, just ignore that. Yeah. All right. So this is the summary of the lecture. So we know it's ablation, and we have found the differences. And linear quadratic model, we found limitations, and what is adding to that shock follow-up. We have given enough evidence that the SRS-based LINAC-based SRS is not inferior, rather is equivalent in terms of the outputs. Rather, sometimes it's more efficient because the SRS is not about a single mat, it's not about multiple mats. And this is good enough. You can use a single isocenter and a little bit of homework, you can pretty much deliver the doses in a single isocenter. We have discussed the prerequisites and for the SRS and MLC, CBCT, and this compliance and all the stuff. This part definitely we haven't discussed in detail. We will be doing that, and because it's not possible for me to really show you these reports, but you need to go into details of what these reports are saying and about the standards. And the second lecture, as I said, I have given this name as the hitting the mark. And this lecture is really after establishing a very good scenario of radiobiological significance. The address will be the central, will be it will be revolving around the geometric accuracy. And the accuracies we are talking about will be, as I mentioned, 0.4, 0.3 of a millimeter. How to achieve that? What are the challenges? What Winston-Lutz test given us a sort of an indication. Because of the imaging complexities within the LINAC, there is a lasers, mechanical isocenter, KV isocenter, MV isocenter, the external imaging isocenter, all those mess ups because of the IGRT and whatnot, how they communicate with each other, how we as a physicist are making sure to develop a correlation, how the LINAC weight is creating problems, why we use non-coplanar beams, and what are the issues with the non-coplanar beams, and how we do the compensation for those kind of runouts. So that is the second part of the lecture. But I'm happy if you can. Do you have any questions, Rana? Over to you.
Thank you, Rahim. It was a nice and well explained, content full presentation. I have got a couple of questions. Maybe I can share with you. You can give us some insight of those. Like someone is asking, like in your lecture initially, you mentioned medical physicists are the one who define the margin for the PTV when we are planning for SRS or SPRT. So, based on what parameter or criteria you are meaning it, and what is the disadvantage and advantages of over it compared to conventional what we are doing currently for some sort of 3D VMAT or IMAT?
I think this question is the core of the whole lecture. I must appreciate the guy who is asking this question. It's a brilliant question because the whole lecture revolves around that margin. And my friend, for him to answer this question, if he is attending the second part of the lecture, he will see that how we are going to define those margins, right? Because without knowing our machine limitations, without knowing our imaging capabilities, we are not in a position to define anything. We are not defined. Yeah. So it will be really very specific. The guidelines are there that how much you can give the margin around, but we as a physicist in the department, based on your capabilities, You can't define anything. Just like to give you an example, just to give you an example that suppose in our department, if we don't have any exact track imaging system, and if I'm given a couch angle of 270 or 90, I know that there is a run out of the couch run out, right? There's inherent run out of the couch, which is up to 1.5 millimeter. So if I'm not doing any imaging and correcting that run out, then I will be really treating something else, not the PTV. And here is the ablation, meaning that you don't have any room for marginal error. Why? Because the amount of dose you are delivering, sorry, delivering is very high. Meaning, if you are radiating 1.5 millimeter of an extra tissue, then you are creating tissue necrosis, right? It's the ablation.
Yeah.
So the second part of the lecture will give us a clear indication how we are managing those minor errors and how we are correcting and what imaging techniques we need to really define so to get enough confidence. Just to give you another example, just to, in continuation, to my friend, if we are using a single isocenter, right? If you're keeping our
Yes.
isocenter middle of the one single mat, then definitely our margins will be different. In that case, particularly, we normally use 1 millimeter or even 0 millimeter based on our imaging. But if something is really sitting in the periphery and at 3 to 4 mets you are treating, then your beam is diverging. Your MLC repositioning, MLC reproducibility, the error gets multiplied as you go away from the central axis, right? So that one
Yes.
millimeter is not going to work. So we will be discussing the single isocenter multi-met target case. Then the concept of the margin will be a little bit different. Yeah. Thanks for this question. Anyway, it's a good one.
Yeah. Thank you. The second question is from my side, actually. I feel like I like your that way of using a word. Like you mentioned that in radiation therapy, we have a safety mechanism. Like we want to control the max tumor as much as we can, and we need to spare the normal tissues, as we all know. But you mentioned you use a term like in SRS, the safety mechanism is geometry, but in conventional, the safety mechanism for the normal tissue is the fractionation. So can you a bit say something bit detail? Actually, why you mean this one? Like, what is
Yeah,
the
because
difference
it
between geometry and fractionation?
yeah. Look, because it violates one of the basic principles, right? SRS, meaning that given 6 hours for a normal tissue, we know that the normal tissue have the tendency to repair. And then tumor cells, while doing that same process, they will get killed in between. But in SRS, you don't have that choice. The only choice is that to hit the mark. If you don't hit, then there is no room. You are doing the same thing to that extra tissue which you are doing to the tumor, meaning necrosis, straight away is ablation. There's no room for there is no room for error, there is no room for margin, there is nothing. So therefore it becomes crucial, right? But for normal VMAT, you can compensate. You have waiting time. You have everything in your hand. You can pretty much play around with the BD calculations. You can compensate if something is missing. You can add on. You can reduce. Pretty much is in your hand. In SRS, you don't.
Okay. So another question I came up, I got someone from, like, if any hospital having an existing BIM model for doing their VMAT treatment planning, so now they are planning for like establishing a SRS program. So what is, according to your presentation, it looks like they need to have another model for SRS treatment planning. So what is your point on it?
Another brilliant question, I must say. Look, it any new modality you are starting in your department, the rule of thumb is to really commission it for that particular case and to do an end-to-end, right?
Yes.
Uh, the reason I was showing you is that some of the beam models are not really tuned to that level. Just to give you another example, I did a project where we found that below 3 by 3, your 6x nominal 6x and 10x, if you plan, the gamma criteria, the gamma passing is going to degrade. Why? The reason is that those beams have been tuned in terms of the DLG and the MLC transmission for bigger field sizes to get the better gamma criteria, right? Either using T90, T119 plans or other. That's what the tuning parameter. But if you just rely on the existing model and believing that it will be right, it will be valid enough to use for small field size, that's wrong. It can't be. So that's the reason you have to go through one-to-one, where I will be showing you in my last lecture that you have to do complete end-to-end testing for any new algorithm you are getting. But it does not mean that you need to really get a new one. If you have an existing one, just like in Monaco, the company is giving you an algorithm which you can use it, but you need to validate it. For example, the CPU which we are using currently, still we are using, is applicable for the big field sizes and small field sizes as well. But now, because of the speed, if you are getting a GPU, which is not just only the acceleration of your calculation time, rather it was a completely new algorithm that the parameters, the Monte Carlo simulation, the working principles behind the scenes for the GPU is different than the CPU. But we are getting the same results. But in this case, the examples I gave you, it may not be, and there are sufficient reasons for that. I haven't discussed the physics behind it, what they have done to increase the speed. But in summary, any procedure you are introducing, you need to do the end-to-end. That's the rule of thumb.
Yeah, thank you. So I think we have some time. So can I have more questions? Do you think?
Oh yeah. We have a couple of more minutes. Yeah, if you can. Yes.
So as you mentioned here in your department, you have an exact track system, right? So just imagine if a department has a XVI and they have a hexapod, but still, do you think they need the extract track, exact track system, or if they don't have it, what will be your suggestion for that?
Um, all the questions are brilliant, really. Um, I will be not comfortable, and again, if I'm saying I'm not comfortable, there is a good reason for it. The second part of my lecture will give you a clear answer why I am not comfortable. Once you
That's good.
kick the couch, everything is different.
Mhm.
I will not be comfortable, but some people does that by giving extra margins, and
Mhm.
giving extra margin is not really a good thing in the SRS. It's not just the ablation, rather you have to control the other stuff as well, right? There's
Yeah.
cognitive and V12, all the stuff. So smaller the margin, the better the, the results. So yeah, but yeah, people does that, but frankly speaking, from the second lecture, you will see it's not something we can do.
So thank you for your nice presentation. I think if anybody has any more question, they can raise it, or maybe they can put their mic on and join us in the discussion.
Yes, Burhan.
Hi, Rahim. Very great presentation. So, in the start, you mentioned about SRS fractions, like it can be from 1 to 5, and then the dose range can be from 8 grade up to 20 grades or even more. Um, and then you mentioned in the radiobiology section that you're like the extra effect of immune system, immune oppression, and then vascular kill
10,
starts
yeah. I
from
understood what
10
you're.
gray and greater.
Yeah, yeah. Now, it's there is a debate, and there are a couple of papers they don't agree, but most of the consensus is developed around the 10 is the threshold where you can call it really, right? But the point here is just to give you an example for the prostate, it's not really crossing that limit, right? It's still 7 point something, still is an SPRT. But as a rule of thumb, normally they say that the vascular damage is happening at 8, 10, but that does not meaning that's not the limiting factor to really um, say that the hypofractionation is should be say we share hypofractionation for the SRS doses or the SABR greater than 10. No, it's not like that. Any dose which is not nominal with the well developed radiobiology which is nominally 200, and why 200, there is again explanation for it, right? um, is the hypofractionation, but we are mostly differentiating SABR and the SRS a little bit on a higher spectrum, but overall is hypofractionation. Yeah, you are right
That's it.
that is 10. Yeah.
And then in the same section, you said bed calculation actually for SRS dosimetry or SRS regime, they overestimate results. But at the end, you showed a table where you compared two things, conventional bed with the SRS bed, and you were saying showing like SRS bed is quite high.
Oh yeah, BD is high. That's true.
Yeah,
But
but
as I said,
where
that's
did you
not the
get?
true. No, no, that's not true. As I mentioned,
That's
that
not
this
a true one.
formalism you cannot straight away apply. It's not the true picture because this is a mathematics, right? But as we
Yeah.
mentioned earlier, that the mathematical formalism is not taking care of the physiological what we discuss in terms of the immune trigger plus it overestimates.
So we
So
cannot
that's not
apply actually linear quadratic
not
model at
not
all.
not in not exactly the way it is. No,
So in case
no,
of SRS, if it's a three fraction treatment and say a patient couldn't come for second fraction, so how do you calculate the gap? Because in the head and neck, the tumors are very, very proliferating. So how do you calculate, or
no,
do
no,
you
no,
mind
no.
gaps?
It's not applicable. Gap calculation is not applicable because the dosage you are given is again the repair is not applicable, right? So one of the R's, which is the important R, which is the
Yeah,
repair
that's my
for
next
radiobiology,
question.
it's not
Why?
applicable.
Why you said redistribution? And I'm talking about if this is three fraction
Again, redistribution is not
treatment,
applicable as well.
but why it's not? Because if you are giving enough time, like it's not gonna be like one fraction and then next hour second fraction. It's gonna be 1 day
No,
fraction per fraction.
no, no.
So
It's
you're giving
applicable.
time,
It's applicable only for the surrounding tissues, not the tumor.
but why?
Oh, because you are increasing the threshold. You are given above the threshold, but sometimes that decision you have to make based on the tumor size, because the bigger the tumor size, you cannot achieve the shelf fall off in terms of the gradient index and the conformity index, right? Pedic index. Because if those just like 5 cm diameter tumor, or you want me to give 21 or 22 gray in a single fraction, you can't. Why? It's not the tumor, it's rather the sharp fall off outside. You can't create that sharp fall off. You can't create. We will discuss the pedic and the conformity index and the pedic index later on, but there is a rule of thumb after sub 2 millimeter in the planning how we encounter that. So the size of the tumor is the limiting factor, not the radiobiology here. It does the ablation, the same thing, but what about the normal tissues? That's the problem, because sharp fall off is the only feature which give the superiority to the SRS. If there is no sharp fall off, that you can't. That's the reason the gamma knife is the gold standard. Why? Because you have those multiple projections through the semispherical environment, right? That's what we try to do, the same thing on the LINAC by giving the multiple non-coplanar beams and giving the multiple projections, so that the concentric beams can hit the tumor and create maximum dose and the sharp fall off outside. So, but again, if the size is higher, you can't do anything, unless if you are really doing SRS with the proton therapy, right, with those drag peak and then create those sort of sharp fall off. Otherwise, with the photons, we know the PDD, we can't do that. We have a limitation.
And also in small field, you mentioned about the sweet spotting. So in our cases, we do follow 483, and it says you need to do lateral beam profiles along the major axis to get the centering correct. So
Yeah.
that's what you mean by the sweet spotting, or
Oh yeah,
something else?
yeah. You have
So
to give a very
what
sub-millimeter motion.
so why there was huge difference? You mentioned, like, if sweet spotting was the one of the reason in your
No, I'm not. No, the
wrong
difference
data.
was not the measurements. I'm not saying
It's
that
a GPU
the difference.
CPU things, but
Yeah, I'm saying it's the CPU GPU. It's not about the measurement. I'm not saying anything about the measurement, but if
so
you are
is there
really interested,
any
anyway, I will
yeah,
have another session with you. But I can show you what I'm talking about. But
we can do it later, I think.
yeah. But I can show you how I did the. But there's your assignment, anyways.
Yeah,
All right. If
thanks
any other
really.
question.
I think everything is fine. So we are looking for the second session next week, Saturday, same time.